Yeah, we are at the top of the hour. Hello, everyone, and welcome to our February 2023 Extended Echo Session. My name is Francis Ochen from the African Society for Laboratory Medicine, your host today. This will be a 1 hour long session, and we'll take 2 presentations and get into the questions and answers before wrapping it up. We'll take only questions through the chat, and so please join the discussion using the chat platform. And we do have language interpretation services. Kindly either the French or the English channel. Today we look at WHO recommended 3-test algorithm for improving HIV diagnosis. As you may already know, there are multiple initiatives that have come up directed at responding to the HIV pandemic, including the UNAIDS 95-95-95 targets. And generally, we know that the first 95 speaks to identification of new cases among all population categories. We also know that the prevalence of any condition in the population has a direct bearing on the ability of any test method or a logarithm to correctly classify those who have the condition as having it or vice versa. And this holds true for HIV, especially where great strides have been made in identifying most of the cases and putting them on treatment and leaving a very small population or proportion of unknown contextual prevalence of unknown HIV status. So in this lowered contextual prevalence, therefore affects the initially competent testing protocols that we have always used, including lowering the predictive values, the positive predictive values, the fact that when you're holding a positive test, the probability that you have the condition actually goes down. And that requires that we work with changes in the implementation environment while reviewing our protocols and also making adjustments so that then we can continuously provide competent services in terms of testing. And so today we are sharing guidelines from WHO that recommends all countries to use a standard testing strategy with 3 consecutive reactive tests at in any situation to provide a positive HIV diagnosis. And in so doing, we'll look at the background evidence and rationale, and then also the benefits of verification studies before deploying any new logarithm, and then how to successfully include dual HIV syphilis testing in this algorithm, and then strategies for making the transition and future planning possible. We have 4 colleagues from WHO who will be taking us through these presentations. And the first presenter will be Dr. Cheryl Case Johnson. Dr. Cheryl is a technical officer with Global HIV, Hepatitis, and STI programs at WHO. Cheryl will have a second presenter, Celine Lastrucci, and Celine is also a technical officer with WHO HIV testing team, also based in Geneva. And Celine has done work as a lab manager and diagnostic advisor prior to joining WHO with MSF. Our third presenter, who will also provide the wrap-up, is Anita Sands. Anita is a technical officer with WHO Regulation and Pre-Qualification Department. She's also based in Geneva, and she's worked over the last 20 years in developing and supporting WHO guidance on quality of HIV testing, including self-testing, and also providing guidance on a lot of other things within WHO. She's worked with Australian National Reference Laboratory before joining WHO. And our last presenter, not the least, is Dr. Alale Abdapour. Alale is an international consultant for HIV testing services, algorithm, verification toolkits, and quality assurance, all with WHO. And so, colleagues, join me in welcoming our presenters for today's session. Over to you, Dr. Cherry.
Thank you so much for the wonderful introduction, and we're so happy to be here with you today. Without further ado, I'll just dive into a little bit of the context of the evidence and the rationale for using WHO HIV testing strategies and algorithms. A lot of what I'm going to share you might have seen before, but I hope that we are able to dive in more deeply today. So I think one of the key driving principles of thinking about HIV testing strategies and algorithms is, as Francis said, understanding where we are in the epidemic and what the gaps really are. And when it comes to HIV testing, we've actually come a long way, especially in the African region. There's been a lot of work done to scale up access to testing through the introduction of rapid diagnostic tests, through provider-initiated testing, and also through the differentiated testing services that we see, like self-testing and partner services or index testing. They've really made a difference. And now we are seeing, particularly in the African region, many countries achieving the 90-90-90 goals. We see high ART coverage. And one of the things that this challenge that we're going to face next here is that as the number of people with HIV that don't know their status declines, it will become harder to accurately diagnose those. And so how do we kind of pivot our testing services for this new phase where we're going to be living in the 95-95-95 era, where we're going to achieve and maintain low HIV incidence? So we have to think about changing our approach to testing because we're entering a new era and new period following a lot of the successes from programs. And so this, as I was saying, in the African region, we've seen a steep decrease in HIV testing positivity, and it's going to continue to decline. So here we can see from the UNAIDS estimates, we've diagnosed between 80 to 90% of all people with HIV now. When we look at the trends over time, we've seen testing positivity across countries decline significantly from around 9% to about 2.8% in the last 20 years. And we now know from our tracking that no country nationally is achieving HIV testing positivity above 5%. And so that is an important threshold that WHO established back in 1997 when we were just really launching a lot of the testing program work, that having high HIV burden settings with 5% positivity in the population being tested was a key marker of the testing approach we would take. And now we really see that we have to change our testing because no countries are really at that 5% threshold anymore. And here's an example just from one country that was really illustrative to what's happening in a lot of countries in the region. Undiagnosed people with HIV has declined from maybe 78% in 2005 prior to ART scale up to now about 14% in 2017 and is projected to around 6% in 2025. And then we see that the overall positivity in this population is now expected to reach about 1.5%. And if we remove those who already know their status from the testing population, this goes down even further to about 0.5%. So overall, if we think about we're testing, in this one example from Malawi, we're testing about 3 million people to identify around 91,000 people with HIV, which is really different than where we were, say, 10 or 20 years ago. And now another important point just to mention when we think programmatically, and we'll talk a little bit about this, is leveraging our testing services has actually become more important for STIs and is going to increasingly become important. We've got global targets now, particularly on syphilis here that I'm showing, that show 7.1 million new infections in 2020, and we have a goal to reduce that by 90%. And in order to do that, we'll actually have to scale up our syphilis testing. And you can see by the bar chart here that when we compare syphilis testing, which is the green bars, to the green dots, which are HIV testing rates, we have a substantial difference where we might be able to actually close the gap if we use innovations like the dual HIV syphilis rapid test as part of our programming as well. And so this is exactly what we recommend at WHO at this juncture, to really have the greatest impact of testing services, bringing HIV and syphilis rapid tests together and using the dual test in both antenatal and in key populations is an extremely effective way for us to address not just HIV, but triple elimination goals, and really something to focus on. So when we recommend the variety of different testing approaches we have, we are so lucky because of the pre-qualification program to have 23 different pre-qualified rapid tests for HIV. These products meet WHO standards of at least 99% sensitivity and 98% specificity. And they include 3 pre-qualified products that are also for dual HIV syphilis detection. So we've included the link here, but these products are very important and you can access them as you think about populating the testing strategies we'll talk about today. So now into the recommendations. So what does WHO recommend as the testing strategy now for HIV? So we recommend that countries use 3 consecutive reactive tests to provide a positive diagnosis. And this has been increasingly noted as important because, as I mentioned at the beginning of this presentation, our epidemic has changed, our strategies are changing because we're going to be getting to this 95 era. And the number of people with HIV who need to be diagnosed is going to keep declining as we achieve that low incidence and maintain that. So we have to support countries that might be using a 2-test strategy, which was a very effective approach several years ago when we had higher HIV burden and we had more people testing positive at the national level. But now we really do need to prioritize shifting away from that to prepare for what's next in our HIV response. And so why do we need to do that? It's really, we have to make sure that we're assuring the 99% positive predictive value. And this is an important piece because if we don't have that kind of predictive value maintained, we're going to end up with more people misdiagnosed and put on lifelong treatment. And that is something we really want to avoid when we think about maintaining the quality of our programs. So this is why we recommend that programs use those pre-qualified tests I just mentioned above, because we want to have fewer than 1 false negative per 100 and 2 false positives per 100 with these tests. And we want to make sure we're making testing services as flexible and easy to get to, using rapid tests predominantly in the African region. So one way to understand that positive predictive value and the shift that we're having in our HIV response, we've just made this very simple graphic that, historically that positive predictive value was really based on having high HIV prevalence in the population being tested. And so when we were looking for people with HIV with our testing services, it was actually quite easy to accurately diagnose them because the positivity was so high and we had so much undiagnosed HIV. But lower HIV prevalence in the population being tested is now the standard, where we're seeing that well below 5% or even 1% and lower, as we showed in the Malawi example. That as we have fewer people with undiagnosed HIV, we have a much lower likelihood of diagnosing people. So we do need that different testing approach. So this is what the WHO testing strategy looks like in response to the shifts in the epidemic. And this is a testing strategy that's actually very similar to what was used in low HIV burden settings outside of Africa since 1997. So what we see here is we have a reactive first test. We would then perform a second test. If that's also reactive, then we would use a third test. And the key differences between a 2-test strategy and a 3-test strategy really come down to a couple components. So there's no real difference here about if a first test is negative in a 2-test strategy, then that's the end of the testing. This person is ruled negative. But when we have someone who might test reactive and they get a second test, we would instantly perform a third test, or we would not perform a third test, and we would only perform a third test if we had discrepant results when we repeated the first and the second test. And that's an important distinction, that to resolve discrepant tests in the previous testing strategy, that's really how we would resolve them with the third test. Now, with the 3-test strategy, we're really recommending that after a reactive first test and second test, we're performing a third test to provide that positive diagnosis. So you can see that in red. We still maintain the same HIV negative after a non-reactive first test, but there is a difference that we are not recommending repeating both A1 and A2 to resolve discrepant results. We're actually only recommending now to repeat the first test after discrepant results. And so that means we are then following up on inconclusives, which would be those who have a reactive first test, negative second test, We would then repeat that first test. And then if it was reactive, we would then report that as inconclusive. So that's a slight difference to the second two-test strategy as well. Now, when it comes to syphilis, and how do we incorporate the HIV syphilis dual test into our strategy, the HIV three-test strategy is the same as what I just outlined. But some key considerations is that the dual test is always going to be used as the first test in the strategy, and that particularly in the pregnant population, anyone with a reactive syphilis test at any point is going to be referred on for treatment. So there is a slight difference here. So now let's unpack an example of how positive predictive value might affect the different testing approaches. So I'm going to just walk through kind of the basic example of a 5% prevalence setting of what it would look like with 100,000 specimens. So you can see here, if we're assuming that 99% sensitivity and 98% specificity, this is where we would end up after a first test. We would really see the positive predictive value about 72%. That's well below that 99% that we mentioned early. That, clearly it's we need a second test to provide a positive diagnosis. And so we can see here that we're just above the 99% positive predictive value at 99%. So if we were able to achieve 5% nationally, that might be reasonable, and that's really something that we used to do. And when we add the third test, we see that positive predictive value goes up significantly, bringing us to almost 100%. And so that, again, giving us that really high quality. Now, the problem is, as our positivity and our prevalence in the population testing goes down, we're not able to maintain that 5% nationally in the group, and different, positivity is being achieved, and it's actually quite low in many groups. And so when we work this example, we can see how positive predictive value changes as the true prevalence in the population changes. So here, showing you after 2 tests, if we're at 1% positivity in the population being tested, we're only achieving 96% positive predictive value. That means that's 40 false positives. And we have 1%, at 0.1%, we're down to even 70%, meaning we'll similarly have that 40 false positives. So we really do need, in order to achieve our goals and have a testing strategy that's really custom fit for 95, 95, 95, to have those 3 tests to ensure that we're giving that accurate quality diagnosis, because in HIV, we're linking people to lifelong treatment, and we want our testing services to really support that treat-all approach and not have any concerns about the accuracy of the diagnosis we give. So just to go a little bit further, WHO conducted some modeling using country data to inform our guidelines. And I'm going to show you just some model comparisons that came out of our analysis that looked at the 2-test strategy versus a 3-test strategy at the varying positivity levels, so from 5% to 1.1%. And we'll unpack some of the key outcomes of the model. So the first thing we looked at in our modeling comparing the 2-test strategy and the 3-test strategy showed us that when it came to false negatives, there were not too big of a difference, but false positives, we did see the 2-test strategy, if we continued using it over time, would increase and have more false positives than the 3-test strategy. We also saw that with the 3-test strategy, we're going to have slightly more inconclusives, but this was a good trade-off because it's related to those false positives. So the individuals we would have previously ruled as false positive under the 2-test strategy, there will be a number of them that are ruled inconclusive. And that's a good trade-off because it's avoiding misdiagnosis, but it does require us to plan on services to follow up with those with inconclusive results in 14 days. In terms of the negative predictive value and the positive predictive value for the 2-test versus the 3-test strategy, we also see that the positive predictive value drops off substantially as positivity declines. So you can see here in the diagram that the red line, the 2-test strategy, really drops off after that 5% threshold and really would not be able to be maintained because of the risk of misdiagnosis. And then there's always the practical question to countries, how is this going to impact the tests we use? Is this going to really increase our costs and our needs for commodities? And what we see here is, not too surprising because we know The vast majority of programs, the cost is driven by that first test. And so the blue area chart here, that A1, that's really what drives costs in testing program, the number of test kits used. And so it really is going to come down to that, where the pink area, the A3, that's our third test, and it has a very limited impact on test use because so few of them are actually needed. So overall, the takeaway here is that we still need to be thinking about how to optimize the use of the first test in our testing strategies. And the third test really has that very limited impact. And to go a step further into our costs, we see overall when we compare the 2-test strategy and the 3-test strategy, the costs, they don't really substantially increase the overall program. And that's because the cost of the program is really driven by the first test in the algorithm. And so the cost ratio shows really that they're very similar in overall investment, and we're not going to really see major impacts in costs based on the program, or sorry, based on shifting to a 3-test strategy in a program. Now, we have sometimes questions about retesting before ART initiation and how that factors in to the 3-test strategy. And I think the first thing I would note is that they're very different in terms of why we do them. So first, retesting doesn't replace the 3-test strategy. It's really a quality assurance recommendation from WHO. Because we are engaged in, diagnosing people and putting them on lifelong treatment, we have retesting as a way to make sure we're addressing human error that can sometimes occur in testing services. Now, when it comes to the recommendation, this was really reinforced when we moved away from clinical assessment requirements to support treat all. And back around that time in 2017, we did a cost analysis that looked at what the cost of retesting before ART initiation would be. And so this table summarizes, what the total testing costs would be compared to the expected lifetime ART costs for those who were truly negative but were incorrectly put on treatment. And as you can see, the expected savings from retesting were substantial, especially in the higher prevalence settings. And then the time to recover those retesting costs were less than a year in both high and low burden settings. So overall, retesting still remains a very practical approach, but WHO does advise, programs to think about ways to, practically implement this. Maybe it's geographically or in some clinics. There's lots of ways to think about how to implement retesting. And we also sometimes get questions about false negative results and retesting on ARVs. And so we've done 2 systematic reviews, one looking at PrEP and one looking at ART and retesting issues. And the challenge with this review and some of the takeaways is that there's so many different factors. It's hard to tease out a specific cause. But what we can take away is that overall, most people who are living with HIV, who are on treatment, who retest, they're going to test positive with the products we have today, which is fantastic. But we do know that oral fluid tests might perform a little bit worse. And so that's something we need to pay attention to, particularly maybe in a self-testing program that's using more oral tests. But there are going to be, patient-specific factors going on. And so it is important that we provide information to clients so they understand if they are living with HIV and that they retest, there is a risk of a false negative, even though that risk is quite low. So to address this in our guidelines, we really point out that it's important that it's very unlikely that we're going to see a large number of false negative results based on people retesting on treatment, but it can happen, especially maybe with self-testing. And so we do need those messages available. We don't recommend programs actively seek out retesting people on treatment to try to identify misdiagnosis, but we do think it's important that clients are aware of the risk of false negative results. And also with PrEP programs expanding, it's really important that we establish infection appropriately and correctly so that we don't end up in challenging spaces where we're trying to resolve complex results, which can take a lot of time and resources. So I know I've run through a lot, so I'm just going to wrap up and hand over to Celine who will go through the next portion of our presentation. But in conclusion, really our findings are that the 3-test strategy substantially reduces false positive misclassifications, and it is really the only way to ensure the 99% positive predictive value target, given where we're headed in our epidemic and our HIV response. We will have an increase in conclusive results by using a 3-test strategy, but this is actually a good thing because it means we're not misdiagnosing people with HIV. but it does require us to think about how we might follow up with those individuals who need to get a definitive diagnosis. In terms of retesting on treatment, this can happen and lead to false negative results, but it is unlikely to be a key contributor of false negative results coming up in programs. In terms of the budget impacts, they're really low when it looks at the 3-test versus the 2-test strategy. So we're not going to see a substantial increase in cost due to the 3-test strategy. But what we do know is that the lowest cost first test is going to have the greatest impact on the program. And retesting prior to ART initiation also is going to save costs. And we didn't even go into all the ethical or programmatic benefits of ensuring quality to a program. And then lastly, for programmatic implications, it's really important for us to think about where we're headed in the epidemic and our response. So maybe to optimize our testing approaches, we need to use things like test for triage or HIV self-testing. That's going to make it easier to roll out things like a 3-test strategy, or even introducing the dual test at the same time as we shift to the 3-test strategy to reduce, transition costs or training costs. And then lastly, on the retesting, this is advised, but it's something that programs can really think about how they might prioritize to make it more feasible based on their needs and their settings. So just thank you so much for your time. I'm very happy to answer questions and just have included some links to WHO and our resources, as well as our emails. If there are follow-up questions, we're very much available to address more details later. But thank you so much, and back to you, to the chairs.
Thank you very much. We will move it straight to Celine. Keep your questions coming, and thank you, the WHO team that is already handling some of the questions in the chat. Celine, over to you.
Thank you, Francis. So hello, everyone. I'm Celine, and I will present on behalf of the team the process to update a national HIV testing strategy and algorithm. So as Cheryl mentioned it already, we recommend to use a 3 consecutive reactive tests for an HIV positive diagnostic. And we have 2 big strategies, one for ANC and K-pop setting, which include dual tests as A1, and one for all the other setting with algorithm composed of only HIV standalone tests. So now I'm going to talk about how to select the most adapted combination of 3 tests. So the tests that are working well together in your context, knowing that we recommend to have the same A2 and A3 tests for both ANC setting and other setting. So what are the principles of selection of HIV testing algorithms? So first, as already mentioned, WHO recommend to use only quality assured products, which mean assays that have undergone stringent regulatory assessment for both the product itself, but also the manufacturing practice. Then the idea would be to use in A1 position the test with the highest sensitivity in order to rule in all positive, the true, but also some false positive, and to use the highest specific test for both A2 and A3 position. And in the end, the correctness of the final HIV status is dependent on the specificity of each of the individual products, so A1, A2, and A3, but also on the probability that any specimen that is falsely reactive on the first assay is not also falsely reactive on the second and the third assay. And this can vary by region. This is why we suggest to conduct a verification study in order to first identify the combination of products which have the minimum possible HIV positive diagnostic. Second, to identify flexible algorithms, so which means that in addition to the 3 tests that will compose your algorithm, you will identify replacement tests that can be used in case of a problem with one of the tests. For example, stock out, batch recall, or stop in production. And the idea would be to select one replacement test for the A1 position, because same characteristic, high sensitivity, and one replacement test for A2 and A3 position, so high specificity. This verification study is not intended at all to reevaluate sensitivity and specificity of each of the individual products, because we feel that we already that are done during the pre-qualification process. So the verification study is really to select the tests that are working well together in your context. Alors, what is a verification study? So the objective of the verification study is to assess the level of shared false reactivity of HIV standalone and HIV syphilis test on the HIV part of the test. It concerns only the HIV line. And how to do that? It's to test 2 batches of 10 to 12 candidate products on a panel of 230 negative specimens in order to identify the best combination plus the replacement test. So why negative sample? Because we are looking to false reactivity, and this can be done with negative samples. So no need to select in your panel positive specimen, which makes this study quite easy to implement. So how does it work in terms of workflow? So the samples are going to be collected from participants recruited in routine testing site after informed consent. Then in the routine testing site, we are going to provide the result to participants in exactly the same way than usual, which means using the current national validated HIV algorithm. And after this is done, samples are going to be anonymized, sent to the reference lab where the characterization is done. And the characterization, it's a 2-test algorithm, so a simple algorithm of 2 tests, because we want to characterize the sample for the absence of HIV. So the algorithm is 1 immunoassays and 1 RDT. We are going to exclude all positive and discordant samples and keep for the verification the 230 negative specimens. We are going to run on this sample the 2 batches of each of the RDT selected for the verification study, and then data analysis is going to be done in order to select the 3-test algorithm plus the replacement test. Alors, what is the process for the algorithm transition? So there is 2 big steps in this process. The 2 first one, the first one is the preparation of the study, and then it's the planning of the scale-up plan of the new algorithm. So all of these steps are quite quick and easy, quick to implement according to our experience. But I mentioned here that the ordering time can vary by country. So this can be one of the, let's say, bottleneck of all this process. So you need to select the best procurement process according to your context. So during the preparation, the idea is to develop the study protocol, to shortlist the essays that are going to be included in the verification study, to order these study tools. Then, when you receive all the material, you can conduct the verification study and choose your testing algorithm. And then, when you have selected your algorithm, you need to scale up. So what we propose to the country is to do an initial phase, a small-scale implementation, where you are going to use the new testing algorithm in a specific number of sites for a short period in order to make sure that everything is ready for the full scale-up. So to support the country to implement the verification study, we have developed a verification toolkit that you can find on the links that I included in the slide, which is a set of tools that are made to support the implementation of the verification study. So you can find on this toolkit a generic study protocol, the product selection tool, a Gantt chart, budget template, an order checklist, and a study database, and it's available in English, Spanish, and soon in French and Russian. So when we say that we need, so we have developed a generic protocol, but each country is going to pre-select different type of tests to select a different number of collection sites. So this is why we say that the generic protocol needs to be adapted to the local context. And then there is also some points that need to be discussed. For example, storage of sample post-study. There is a need to adapt also the informed consent to the local population. Then when you have adapted your generic protocol, you can seek the ethic approval and adapt your study supportive tool. So one of the most important part of the process is the selection of the candidate assay that the country wants to implement, to include in the verification study. And this needs to be done based on the performance and the operational characteristic of the test, which are equally important. So for that, to support the country doing that, we have developed a product selection tool which put all together the performance characteristic and operational characteristic of each HIV standalone WHO pre-qualified test, RDT and immunoenzyme assay, and also the HIV syphilis dual RDT. So how to use this selection tool? So the country will have to look at performance characteristics, so sensitivity, specificity, subtype detection, but also operational criteria, shelf life, storage condition, easy of use, result stability, packaging, and the cost. Just to mention that the cost that we have included in this tool are the WHO negotiated price, so it might not be exactly the same price than in country. So then the idea is to weight these different criteria to have an order of importance according to the local context, according to the user, according to the climate, according to the procurement system, and according also to the preference of the user of the test. And in the end, by doing that, you will be able to choose at least 10 tests for the verification study, including 4 to 5 tests for A1 positions, so very high sensitivity, and 5 to 6 tests for A2 and A3 positions, so with very high specificity. And we recommend to include tests from different brands because, of course, it's not recommended to include in the same algorithm different tests from the same manufacturer. Of course, you need also to include dual HIV syphilis RDT if the country intended to use this test for ANC or KPOP setting. And you will need to select the characterization test, which is one RDT, not intended to be included in the national algorithm, and one immunoenzyme assay. Alors, how to establish the verification panel? So we want this study to be easy and quick to implement. So we have used a very pragmatic approach to make it easy to implement for country. So for practical reason, this study can be used on plasma specimen because we need to have a large volume of sample. The specimen, so the 250 specimen, should be collected from clinical setting. So in order to be representative of the populations that are going to benefit from the new algorithm, so a mix of antenatal, KPOP clinic, general population testing site. But for practical reason, specimen can be collected close enough to the reference lab to avoid complex transportation route. And specimen should be adequately characterized for the absence of HIV, so with a 2-test algorithm, one EIA and one RDT. So again, you are going to exclude all positive and discordant sample and keep in your panel only the HIV negative specimens, so the ones that are negative on the RDT and also on the immunoenzyme assay. So we have developed a tool to support the country to order everything that is necessary for the verification study. So we have included in this tool the list and quantity for everything that is needed, reagent, test kit, and consumable. So it needs to be, we put everything, and we know that the country might not need everything. So this tool needs to be used as a checklist, and you need to adapt to country context and ordering process. For the study site, so the verification study may be conducted in any setting, lab or point of care as designated by the national authority. But again, in order for this study to be easy to and quick to implement, logistically, it may be easier to conduct the verification study at the national reference lab, which means that the sample collection will be done in the routine testing site, and they are going to transport the sample in the verification in the national reference lab, where plasma separation, aliquoting, and testing is going to be done. Of course, the staff, all test operators, should be trained on the relevant SOP, which include how to handle the sample, how to perform each test, how to read and record the test result, and this training should be documented in the training record. And then when everything is set up, you can conduct the verification study. So to use the 10 to 12, two batch of the 10 to 12 RDTs that you have pre-selected on the verification panel, and then you can do the analysis. So what you are looking for is to identify the product displaying the lowest false reactivity in your context, and identify the product sharing the least number possible of false reactive results. And with that, you will be able to choose the HIV testing algorithm for the what we call general population, ANC and /KPOP setting, and the two replacement tests. So now that the country has defined its new algorithm, it's time to scale up. So what we propose to the country is to do a small scale implementation when you are going to run the new three-test algorithm for 1 month, 4 to 6 weeks, in a specific number of sites that needs to be representative of the health pyramid. And in a routine context, you are going to check that everything is ready for the national scale-up, which means that the idea is to build user proficiency and confidences. So there is a need to update all supportive tools, SOP, Benchhead, training module, etc. Then you will be able to assess feasibility and acceptability of this new algorithm. And from this experience, the countries will be able to draw the lessons learned in order to develop a really precise scale-up plan. Some things that need to be done also during this period is to update all normative testing documents, and also to register the product if the selected products were not already registered in country. Voilà. So, and the last tool that I wanted to talk about very quickly is we have developed a verification study budget template, which includes a list of all mean and resources for a 10-test verification study. The prices are really indicative and need to be adapted to the country context. So this tool needs also to be used as a checklist. In conclusion, what I wanted to highlight is that one of the most important part of all this process is the pre-selection of the test, and this is context dependent. Performance and operational criteria needs to be taken into account according to the local context. The number of tests to include in the study, don't forget that you will have to select 5 tests in total. 3 tests for your algorithm, 2 replacement tests, plus 1 dual test. So in order to make sure that you have enough options, even if shared false reactivity are identified, we recommend to pre-select at least 12 tests. So according to our experience, and a second section will be specifically of country sharing experience, this study is quite quick and easy to implement when the supply is on site. The sample collection takes 5 to 10 days, sample characterization 2 to 4 days, and verification phase 8 to 10 days. So it's really not so complicated to implement in country. The false reactivity and shared false reactivity profile are different between country by country, so it's important to run this analysis to optimize HIV algorithm selection. In terms of country decision making, what we have seen is some countries that decided in the end to continue using the same test if there is no issue of false reactivity, of course. It was mainly for continuity and training purpose, but some other country took this opportunity to change because they identified new interesting new tests, maybe less expensive tests, and it was used to boost the market and to select cost-saving algorithm. Alors, for the procurement delay, it can be quite different between countries. So the recommendation is to identify the best option for your context. So I wanted just to acknowledge all the people that have been involved in the development of this verification toolkit. And I'm open to any comment and questions. Thanks for your attention.
Thank you very much, Celine and Cheryl. The other two presenters will help us with the questions and answers and also the wrap-up. A fascinating and quite informative session. I have quite a number of questions in the chat, and thank you again to the team. We've dealt with a number of them as well. Again, we have been told of what is available, the WHO pre-qualified list of rapid kits for HIV diagnosis. We are also told that we need 3 consecutive tests that are reactive for us to make an HIV positive diagnosis call. And we know that as the positivity rates go down, we are supposed to only but keep our predictive values, the positive predictive values up, if our results are to remain valid. And of course, verification studies for the entire algorithm is key as we move to the 3-test recommendations from WHO. With those, we have so many questions. I'll start with the relatively simpler ones, but very interesting questions. Lisboa from Mozambique is asking, their prevalence currently stands at about 10%, with their positive predictive value of about 99.6, using the test, the 2-test protocol. So what is the guide to them? I hope that the 10% alluded to here is the 10% of those who do not know their status, not the general 10%, including those that are already on treatment. But I'll leave it to Sherry and team to deal with this question. If a country has a prevalence of still higher than 10% or 5%, which is your benchmark, what is your recommendation and guidance?
Yeah, it's a great question. So I think the first thing we have to establish as a principle is that the overall national prevalence is no longer a good benchmark of the testing strategy you may pick. And that's because countries that even have high burden, like a 10% national prevalence in adults, a lot of those individuals are already on treatment. So one metric that WHO advises that you could consider here is called treatment adjusted prevalence. And so this is a basic calculation that you can make. And I'm very happy to share the link to this paper and to the guidance where you basically are taking the total people in the population with HIV, you're subtracting those who are on treatment out of the population, and that gives you this treatment adjusted prevalence benchmark. So in most cases, just as an example, you might see out of a 10% national prevalence, because treatment coverage is so high now, your treatment adjusted prevalence will be closer to 2% or 1% often. And so we can share that information and put it in the chat. So I think that's important because the positivity or the prevalence in the population being tested is significantly different than the overall prevalence in a country. And as a testing program, we don't see any countries with data at a national level where they're achieving 10% positivity nationally. So I think that's the point that you would really want to focus in on, is that that's not really what we're seeing. We're seeing countries nationally with their testing programs achieving something closer to 2% positivity maybe or less. And so, very happy to address, specific questions, but we're talking about national testing algorithms. We know certain testing approaches might have higher positivity, like an index testing program, but that's very different than what you're seeing nationally, say, with testing children or testing at antenatal care. And so we need to think about our testing strategies from that bigger picture perspective, and also think about our understandings of prevalence in the population being tested are really different than thinking about the overall prevalence estimate in a country, which includes those on treatment.
Sherry, have I lost you?
I think she's done.
Okay, so thank you. I thought it was my connectivity. Yeah, so a few other questions here, and they relate to the added value of getting the third consecutive reactive test versus cost, really. And this has come from Lisboa, Lavania, and Lateng, many others, asking, in terms of cost effectiveness, what is the additional value? And I know that this has been dealt with a bit in the presentation, but just Celine or any other colleague from WHO, if you could just wrap it up again on cost effectiveness of the third test.
Okay, so what Cheryl mentioned in her presentation is that basically the cost of the testing is driven by the A1. And because we are doing so many A1 and not so many A2 or A3, because the positivity is quite low, the increased cost because of the third test is not significant. So basically, the cost of a two-test algorithm and the cost of a three-test algorithm is almost the same, and the difference is going to continue to narrow because, again, the positivity rate in testing stack is going to continue to decrease. So the cost is driven by A1. So the country maybe needs to think really in terms of cost of the program about the A1 test. But the A3 does not add so much in terms of cost.
Thank you, Celine. We have yet another question coming in from Geoffrey, and Geoffrey is asking, when is this guidance expected to be rolled out in countries? And when we start, which population, which clients categories are expected to benefit?
Cheryl, I start and you complete if you want. So the guidance is released, this guidance of a three-test strategy for all is released since 2019. And after, there is a time for the country to adopt this new recommendation. So some countries have already moved from a two-test to a three-test strategy. For some countries, it still need to be done. For which population first, that we need to apply this testing strategy first. In fact, we recommend to use the same testing strategy for all the population in country. So a three-test strategy for everyone. Voilà, I think I might have answered. I hope I did answer to all the question.
I think the only thing I would add, Celine, is that we understand many countries are applying for the, putting their funding requests together for NFM4 with Global Fund. And they have indicated at the Global Fund that transitioning to the three-test strategy is a program essential. So it's going to be very strongly advised that countries adopt the three-test strategy. And again, this is really coming from the direction that all programs now, because of declining positivity and the success, we want to prepare for the future of maintaining that low HIV incidence. And this is really the direction that all programs need to go.
Thank you. I have the next question coming in from Eric, and Eric is asking, I think the general appreciation on his side is that for inconclusive results, the testing will be done off-site, and you will have to weigh in there to correct that. But the question is saying, for inconclusive reactive tests, if they have to be referred to other facilities, what are some of the considerations given the very many referral challenges that come to play when moving test samples between labs?
Maybe I could answer that question if
Please
it helps.
go on, Anita.
Yeah, sorry, it's Anita here. If this helps Celine and Cheryl. We actually don't see that you need to refer a person to another facility. The HIV inconclusive results can be resolved by a visit to the same facility 14 days later. The reason we say 14 days is if you're reactive on assay 1, but non-reactive on assay 2, there are two possibilities. One, you're false positive on assay 1, or 2, that you're seroconverting and assay 1 has been more sensitive and been able to pick that up. After 14 days, you'll be able to determine if it's false positive or if it's actually seroconversion. So it actually is better to go back to that same health facility, have the same testing algorithm applied, and that will actually help you to conclude one way or the other much more quickly. Over.
Thank you, Anita and the team. I have yet another question coming in from Nagale Eliv, and Eliv is asking, in a 3-test strategy, will a repeat of the first test be expected for the same diagnostic kit used, or should this be done on another kit? I will ask that you also merge this question with the general observation on when doing verification for your logarithm, the multiple kits that can be used, and therefore having some kits that in combination can support testing, but not necessarily may be used at any one time, so that then you can deploy them in cases of stock out or stock recall, batch recall, so to say. So if you could just try and merge these two questions. Do you have to use another kit classified as kit 2 or kit 1 in your repeat testing, or you can use the same kit? And then marry that with multiple combinations that you can work with to try and deal with anticipated stock challenges.
Okay, alors, to retest the patient when they face inconclusive results, so A1 and A2 that are discordant, then you need to repeat the A1 test. And for this one, we do not necessarily recommend to have another batch of tests, because we feel that by repeating the A1 with the same batch of tests, it's enough to avoid all the mistakes that could have been done with the first test. To repeat the testing when before putting someone under treatment. I think that it was also mentioned by Cheryl. One retesting that we recommend to do, it's a new patient newly identified as HIV positive, is retested using the same algorithm and put on treatment only if the repeated test is also positive. For this part, what we recommend as best is to do this testing with another batch of tests and another user as well, and on another sample also. But we know that it's not always feasible to do that in every testing site. Sometimes, anyway, the treatment is not done in the testing site, so they could retest in the treatment site, for example. In some tests, it's the same site that is doing everything, so it might not be easy to have another batch of tests, but in that case, at least another user and another sample. So after, it will depend of the situation in the site. But the objective is to be able to correct any mistake that could have been done in either the identification sample versus patient or the test procedure itself. Over.
Thank you. Thank you very much, Celine. And Anita, just prepare to do the wrap up. There is a question that is coming up on, do we have to do a retest prior to initiating ART? I know the guidelines in multiple places is that for anybody who is tested positive, you have to do a retest prior to initiation on ART. And the 3-test protocol does not change that, because for you to call somebody positive, they must have had a reaction on all the 3 kits. And it is only up until that happens, then you can call a positive diagnosis. And then those are the people that can then go for retesting prior to ART initiation. Again, let me just hand it over to Anita to do the wrap up for the session. I know that there are multiple questions that are still running in the chat. Anita, over to you.
Thank you so much, Francis, and thank you to everybody who has been making questions in the chat. I think it's really helped us to narrow in on what the common questions are. But I think just to underscore what Cheryl said, the HIV epidemic has changed than what it was a decade ago. Positivity rate is declining, which means the testing strategies that we used to recommend are no longer fit for purpose. People are on ART, they're coming back into the testing cascade, which means that molecular tests are not always going to be able to determine those people's diagnosis because they will be undetectable and therefore negative on most NAT tests. We also know that as positivity decreases, when you have a reactive result, you're actually more likely that that is a false reactive than a true reactive. So what we really have to be concerned here is about false positivity. And Celine also demonstrated to you a way that you can actually be empowered to help detect, to determine and select which products work best for your setting in this new testing strategy where you need 3 products, and how can you make sure that the 3 products that you select don't share that common reactivity. We also think this will enhance your ability to have a flexible testing algorithm, so more than one possibility for assay 1, and maybe 3 possibilities that can be either assay 2 or assay 3. And we think this will help to minimize the possibility of stockouts. It helps to make your market a little bit more interesting. Hopefully it'll bring more people to supply rapid tests, hopefully at cheaper prices. And that means that you can minimize the cost of providing testing overall while maintaining accuracy. And we're very much happy to be here to support you on this journey to transition from one strategy to the other and to select perhaps new products for your testing programs to use. Over.
Thank you. Thank you very much, Anita and team. A very good session indeed, very informative. We encourage country teams to get to their WHO in-country offices for additional information. We'll share the slides here so that you can as well get to the links that are available in the slides and still make use of whatever it is that you may need to get done through this. We are now requesting that you can get to the ASLM Academy and download certificates to demonstrate your attendance of this. Also, we are requesting that you can activate your cameras. In the background, my team will want to take some few screenshots. So it's now time you can activate your camera. I know FitSum is enabling that function so that we can take a few screenshots for some of the records that we will need. Thank you again. This is a loaded week. We have another session on Thursday. Be on the lookout for the flyers just after tomorrow. And we believe that it will be another very good session for you to attend. And with those, we will meet on Thursday. Thank you and over.